Good morning. This is Dana Parsons, and thank you so much for joining us for our coronavirus weekly member update. We know that you're all very busy, so thank you so much for taking the time to join us. We'd like to begin today with our Virginia Hospital and Healthcare Association update with Kelly Parker.
Thank you, Dana. Can you hear me okay?
Yes, we can.
Great. Thank you very much. Good morning, everyone. Kelly Parker here at VHHA. Just want to provide you a brief update and continue to thank you all for the work that you are doing and are continuing to do on the front lines of this response. We'll give just a brief update on some of the numbers that we're seeing from the hospitals and the long-term care side, and then I'll talk briefly about just the initiative we're kicking off this week with long-term care facilities. So as you all probably know, the hospitalization rates and what we're seeing going on in hospitals has remained relatively consistent over the last number of weeks, thanks to social distancing efforts across the Commonwealth. We're roughly at about 1,500 cases of confirmed or pending hospitalization in hospitals across Virginia. We have roughly 2,917 ventilators, and 603 of them are currently in use, which is about a 21% utilization rate of ventilators at this time, which is also relatively consistent and has been consistent over the last many weeks. When we get to our bed availability for our hospitals, traditionally, since we had canceled scheduled procedures due to the governor's executive order, we had stayed around roughly 5,500 available beds. However, with the expiration of that executive order on May 1st, scheduled procedures are beginning to resume, and so we are seeing that our bed availability is going to decline, which we anticipate. So we are at about 4,700 beds available right now under current licensed beds. In addition to that, we have under Executive Order 52, we've got roughly 3,700 additional beds that our hospitals have opened up or have created in order to take care of the surge needs that would or could potentially arise should we open up the Commonwealth again. So while we expect our bed availability to decline, we do anticipate that we'll be watching really closely the number of case counts and our ventilator utilization rate to determine if we are experiencing a surge of COVID patients. We do the same report for the long-term care facilities through our VHOS system. So as of this morning, we've got 1,094 reported confirmed positive cases in skilled nursing facilities. So that does not include assisted living facilities. We have 295 pending cases. We're having great response rate from our long-term care skilled nursing facilities on our VHOS reports, so I thank you all very much for that. We are also continuing to track PPE shortages. We have roughly 16 facilities that have reported N95 mask shortages, 7 that have reported difficulty with surgical masks, 7 having difficulty with gloves, 12 with face shields, and 25 with isolation gowns. We do know that isolation gowns are a big issue right now. We're also experiencing some of those shortages in our health systems. Our coalitions are working diligently with the state to get distributions of state-acquired PPE to the coalitions so that they can deliver them to the facilities that have needs. So I encourage you all to continue to work with your regional healthcare coalition and try to obtain supplies that are being delivered to them. I will say that the state has not received all of their shipment of supplies, so we are getting our hands on supplies as they become available, and unfortunately they still don't seem to be meeting all of the needs that we have, but we'll continue to receive supplies from the state and ship those out to you all as the needs arise. The last thing I would update on is the initiative that we're kicking off in partnership with the Virginia Department of Health and with LeadingAge and VHCA. We hired a contractor, brought on a contractor called Russell Phillips and Associates. Many of you may be familiar with them, as they are the ones that did the surge assessments in all of the long-term care facilities over the last number of years, and their work led to the development of the Virginia Long-Term Care Mutual Aid Plan and Memorandum of Understanding, in which a majority of your facilities are members of. We brought them on as kind of some extra bench strength They are kind of the national experts in post-acute care, emergency preparedness and response, and they've been working in a number of states with long-term care facilities that have outbreaks, obviously doing the same thing that we are going to hope that they are going to do for us here in Virginia. And so what we're doing this week is kicking off a series of regional calls. We've identified leaders in the long-term care world, the assisted living world, and in the hospital world to participate in these regional calls to really determine what the needs are from your facility levels and how our hospitals can partner with you to help those needs. We know what the immediate needs are, but we also know that this is going to be a long-term response. And so we're looking at areas in which our hospitals can partner on planning, infection prevention, potentially staffing, and really meet some of the long-term needs of your facilities. And so we're going to have Russell Phillips kind of come in, be our SMEs on those calls, help us develop those plans, and really determine where we can pull resources from our hospitals to help you all. So as I mentioned, we're kicking those calls off this week, and really looking forward to kind of getting started on that initiative. We do know there's a lot of great facilitation and participation already going on in the region, and we just want to continue to reinforce those partnerships and then expand on them where possible. I think that's all I have, Dana. I'm happy to take questions now or at the end, however you'd like to handle that.
Thank you so much, Kelly. And we appreciated the information that you gave us earlier this week from FEMA regarding the distributions. Did you have any updates as far as when communities might, I know you had mentioned it earlier, but might be able to expect their distributions? We've just been receiving some inquiries, and Sarah may be the one to answer that. I'm not sure.
Yeah, unfortunately, the information that we received in terms of the distribution quantities is about the only information that we've received. We were told that they were going to start shipping, I think, the second week of May, so potentially next week. But this is a national initiative, so I'm not sure how they're prioritizing how shipments go. So unfortunately, that's all I have at this time, unless the VDH has anything else. But you know, as soon as we receive more information, we will share it with you all. I'm not confident that we will receive any more information. So just be on the lookout, I think, is my best advice for the delivery.
And what if a community, I see we have some questions coming in, so I'm going to hand that over to Melissa.
I think you were doing just fine, Dana. What if a community, and this might be either Sarah or Kelly, what if a community is not on the list and they should be to receive the FEMA supplies?
So I know I received one of those inquiries today. If you all can share with me the contact information of the facility, the name, the address, and the point of contact at the facility, I will send that information back up to the state and see if they can coordinate with FEMA to get them a distribution.
Okay, thank you. Yeah, that message was for me, so I'll send you that follow-up information. Thank you.
And then another question is, why is the national stockpile of PPE not supplying PPE to long-term care?
So the Strategic National Stockpile distribution was received in March and has been distributed to a number of partners in the healthcare world. 40% of that distribution went to healthcare, which was hospitals and long-term care facilities. And for long-term care facilities, the process to obtain that information was to contact your regional healthcare coalition, in which a majority of facilities have done if they've had needs. And I know our coalitions have sent a lot of that. Those supplies have been distributed to long-term care facilities. So the direct shipment from the Strategic National Stockpile to long-term care facilities did not happen, simply by way of there was not enough supplies to even facilitate that type of distribution. So that's where we went with the Regional Healthcare Coalition route. The FEMA supplies that are being delivered are separate from the Strategic National Stockpile. That's a separate federal agency, and that is based on procurement that FEMA has begun doing on their own. Additionally, the supplies that the state now are delivering to our healthcare coalitions are not part of the Strategic National Stockpile, as those supplies have been exhausted. The supplies that are being delivered to the coalitions for distribution to long-term care facilities are part of some FEMA distributions to the state, as well as the state's procurement of supplies on their own through a partnership with a manufacturer they have in Virginia. The additional strategic national stockpile, as I mentioned, 40% went to healthcare, which included hospitals, long-term care facilities, dialysis, and DBHDS. There was a portion that went to DSS for assisted living facilities. There was a portion that went to local health districts for home health, hospice, and outpatient care settings that were still seeing patients. And there was a portion that went to the EMS community as well.
Great. Thanks, Kelly. That's all the questions we have for now, Dana.
Okay, great. Thank you so much, Kelly. We appreciate the update. Thanks for all you're doing for us. So now we're going to hear an update on lessons learned from Sarah Lineberger with the Virginia Department of Health.
Sure. Good morning. So we have over 20,000 cases of COVID-19 in Virginia, and we have 252 COVID-19 outbreaks that are confirmed. Again, that means there are 2 or more cases. Of those outbreaks, 146 are in long-term care facilities. So that's actually, the percentage in long-term care facilities has actually increased this week. About 58% of total outbreaks are in long-term care facilities, including nursing homes and assisted living facilities. I want to make sure that you all continue to check in to the VDH website for health professionals, and I'll put that link in the chat. There's a long-term care section, and we continue to add resources there and update resources. We do have a very long VDH guidance document that got posted this week, and with that we tried to summarize all of the CMS and CDC guidance, recognizing there's a lot of different guidance sources. And our goal is to keep that updated. Even though it was posted yesterday, we'll probably do another update today as CDC and CMS guidance continues to evolve for nursing homes. And there's also other tools there on the website, like a new employee screening form that has more symptoms included and some other materials that might help that we continue to update as we learn more about the virus and the outbreaks that are happening. Dana asked me to talk to the point prevalence surveys. So we are expanding capacity in Virginia to do point prevalence surveys, and long-term care facilities with outbreaks or at least one confirmed case are priorities for point prevalence surveys. We are the resources of the Virginia National Guard. Some of the facilities on this call may have already done a point prevalence survey with the National Guard. I think those are going pretty well. The National Guard brings test kits to the facility and does the actual swabbing of residents and staff, and then takes the swabs and drives them back to the lab for processing. And so we have a couple resources we're capitalizing on. The National Guard is deployed in Virginia on their current missions through the end of May and has time and resources to do more point prevalence surveys. And then we've also, our state leadership has worked to bring on other labs to do testing to support this. And so before this week, we were sort of doing point prevalence surveys when you all requested them, and we're moving to more of a push method where the health department will be calling facilities to ask if you would like to do a point prevalence survey. These certainly aren't required, but we feel like this is a helpful resource to better understand what's happening in the facility. And so that's only going to increase over the next couple weeks, those resources. Dana, what other questions did you want me to speak to about point prevalence surveys?
Well, we are very fortunate that we're going to have Barb Brandon on next, who's going to be talking about her survey experience I just would ask that all on the call, if you have any questions, if you can put those in the chat box. In our daily update today, we will be including the guidance as well as an FAQ that the Department of Health has provided about this process. So that will be in our update today. I don't see any questions coming in, but if you do have questions, there's one. Let's see. Is there any plan on the horizon to allow testing of public-facing staff of life plan communities, such as marketing staff, to reassure that the public, that the contact is safe?
I'm not sure I understand the question.
So I would say that that wouldn't be something that would happen through the Department of Health unless there's an outbreak. I think that's one of the reasons that our members are trying to get their own test kits so that as they need to test staff, they can do that. But, you know, right now, because our campuses are on restricted visitation, I don't think folks like marketing staff, unless they're doing other things and become symptomatic, would be a priority.
Right, so we do feel like it's important when we do a point prevalence survey in a facility to test both residents and staff to have a sort of a complete picture of what's going on in the facility. The facility can certainly weigh in to what staff they would like included, but the focus would be mostly on staff with direct patient contact. So in terms of marketing staff, I think that would just have to be a discussion. And I agree that that might need to be done through another testing avenue. There's another question, can testing be mandatory for staff for point prevalence surveys? I think that's a really good question. This isn't mandatory, but strongly encouraged, and we understand that some staff are hesitant to be tested, and certainly look to facility leadership on encouraging their staff to be tested or how to handle staff testing. I don't know, Dana, if you have any comments on that.
No, I don't at this time. Some more questions are coming in.
Yeah, so one of the questions that came in, Sarah, what is VDH doing to improve availability of tests?
So like I said, we're creating state contracts with additional labs, and so that will increase our daily testing capacity. So our state public health labs, UCLS is still testing. We still have partnerships with a couple of universities who have been doing testing to support these point prevalence surveys, but we're bringing on additional labs and essentially using state dollars to pay for that testing.
Another question came in looking to the future. What is the availability of test kits to communities? Sarah, what are your thoughts on that?
I am not sure I'm the right person at the health department to answer that question. I mean, I know there's work being done on that. We will be increasing contact tracing because as we test more people, that means that more contacts of positive folks need to be tested. In terms of test kits for the communities, that's certainly happening now with these increasing lab resources. There are some communities doing community testing events, for example, in low-income neighborhoods and other areas where resources may be limited or folks just don't really have regular healthcare providers. So that's also increasing at the same time that the point prevalence surveys are increasing in long-term care facilities.
Yeah, and I think that's one of the reasons we have members who have looked to outside, private companies to buy testing kits from them. There's an expense associated with that, and they have to send them out to labs. But I think there continues to be kind of this confusion, Sarah, on when the Department of Health is providing the test kits and when providers need to look for some themselves.
Yeah, so VDH did update our testing criteria, and I can put a link to that. I think that was this week. So I can put the link for that in the chat. Let me just pull it out. It's just going to take me a second to pull it up. So there are high priorities and priorities for public health testing, and we're supporting these point prevalence surveys, especially for long-term care facilities and some other settings like Department of Corrections facilities and local jails. Beyond that, I think the availability of private testing continues to increase as well.
And then there's a shout out and a question on the adult day side, Sarah. So thank you for the employee screening template. As adult days are gearing up to open again, this is so valuable. Followed with a question, can adult day centers get test kits, and who would administer them?
Yeah, I think that's a good question. I don't think I have a good answer right now, so let me try to get more information on that.
Hey, this is Laura Cornegie. I'm going to be talking about testing in a few minutes, and I think I may be able to answer some of the questions.
Oh, great. Thank you.
Laura. That's all I've got, Dina.
Okay. Well, thank you, Sarah. We really appreciate the update and all that you're doing for us. Thank you so much. We are going to actually continue to talk about the point prevalence survey. Falcons Landing recently experienced that. So I'm going to hand it over to Barb Brannon to talk with us a little bit about her experience. Barb? Okay, well, we'll come back to Barb. I think maybe she might be having a little technical difficulty. Dr. Cornegie, if we could go on and begin the discussion about best practicing with testing, that would be great. Thank you.
Oh, sure. Hopefully I can answer a few of the questions. I think our emphasis in May in terms of Virginia Department of Health is really to increase up testing. The governor has asked that we test approximately 2% of the community. So for Central Shenandoah Health District, that would be about 6,000 people, and it's probably, 170 some thousand people across the Commonwealth. In order to be able to do that, we have gotten access to testing kits via FEMA, the NP swabs, as well as the viral transport media, and as Sarah said, have contracted with some private labs in order to ramp up testing capability. DCLS, our state lab, is able to test. University of Virginia has testing capability. Virginia Tech has testing capability, and then there are a number of commercial labs and probably other entities that can test that I didn't mention. So I think over the last few weeks, our testing capacity, has greatly improved. The Department of Health, as a sole entity, is not going to be able to accomplish all of this testing. So we're going to have to depend on partners within the state to help with that, be it healthcare systems, FQHCs, and others within our communities. In terms of local health department priorities for community testing, as Sarah said, we're going to try to target unserved and underserved communities, folks who may not have access to health care, areas of high need that have been identified in communities. We're working with all of our emergency management partners to try to identify those target areas within the communities, and to work in conjunction with the National Guard, who can help us provide
Please enter your access code
with local health departments. Um,
I'm sorry, Laura, we're having some technical problems, so we had to mute you. And I think you said some things that we'd really like to hear, but we were not able to hear them because you were muted. I apologize. I think you'll need to.
can you hear me?
Yes, we can hear you now. Thank you.
Okay. I'm not sure where I finished. I guess I'll start.
No, it's somebody else she's saying is muted. Dana, can you hear me? This is Barb Brannon.
Yes, Barb, we hear you.
Oh, okay, sorry, much confusion. I kind of got muted and I couldn't figure out what was wrong.
No worries. We're going to have Laura finish up and then we'll turn back to you, Barb.
Fine, mute me. Are you going to unmute me and mute me then, and I don't need to try to do that again?
Why don't you just stay unmuted?
I shall, and I'll be quiet. Thank you.
Thank you.
All right. So May, as I was saying, is kind of the month of testing. The governor would like to get 2% of the population tested over the month of May. In order to do that, a few things have happened. One is the state has gotten assets from FEMA that include the testing swabs and the viral transport media to support the test. And then, as Sarah said, we've contracted with a number of labs to be able to run tests. We'll be doing point prevalence surveys in nursing homes, and to the best of my understanding, those will happen via the National Guard. LeadingAge has identified some high risk areas that they want to target, but I think we'd have hopefully availability beyond even those high risk areas to do point prevalence surveys. The local health department will be working to increase community testing, and we'd be trying to reach underserved areas of our community, particularly people who are uninsured, underinsured, people who lack access to health care. We're working with our emergency management folks and some social vulnerability maps produced by the CDC to target areas within the communities, and we're going to partner with the National Guard to be able to do testing out in our communities. The test kits themselves have been paid for by the state, so that would remove finances as a barrier to care. We will not in any way, shape, or form be able to test 2% of the community just using health department assets. So we'll definitely have to look towards our community partners, healthcare systems, FQHCs, private providers, to increase testing so that we can kind of follow that trajectory as a metric to decreasing social distancing. The governor, one of the metrics that he is looking at is the percent of positive tests, and seeing that over the course of time. So increasing testing to provide that data is really going to be critical. Sarah sent a link to the current priorities, and high priorities continue to be congregate settings like long-term care facilities, healthcare workers and first responders, and hospitalized patients. Kind of the second tier of priorities would be people with COVID-like symptoms, and then screening persons without symptoms, such as perhaps preoperative, cases and others within the community. DCLS is our state lab, and really their kind of general role in life is as a public health testing lab, and really not as a high volume diagnostic lab. So over the course of May, with the increased commercial availability of testing, DCLS is going to try to migrate back to their core public health function, and that would be really concentrating on outbreak situations, concentrating on testing selected contacts, and public health monitoring and sentinel surveillance. Our best testing continues to be PCR-based testing, which tests for the virus itself. There are serology tests that are available. The sensitivity and specificity of those tests not clear at this point, and I know our state lab has not made any recommendations in terms of use of those tests at this time. So that's kind of my update on testing. I'd be glad to answer any specific questions that people may have, and I can look in the chat box here too to see what's come up.
I see two. One is, what is the current effectiveness, reliability of the tests?
Currently, the sensitivity and specificity of the test is high, so that's a good thing. We consider a positive test a positive test, and the test no longer needs to be validated by the CDC, which was kind of how we started 2 months or so ago. A negative test is a snapshot in time. So a negative test means that you're currently negative today. However, that doesn't exclude development of symptoms and diseases in the days to come. So that's something to consider in terms of a point prevalence survey, that the negative testing is certainly reassuring for that point when it's done in time, but it doesn't guarantee that that person's going to remain, negative in the long term. So the point prevalence survey is a snapshot in time about what's going on in your facility or your community. It gives an idea of the overall burden of disease when you look at the positives, and it gives you an indication of, how many people are negative at that point when the testing was done. The negative testing really can't be used as a get out of quarantine card. For that reason, we get asked that a lot, that again, we set the quarantine period if you've had exposure as 14 days, because that seems to be the general length of the incubation period. If you have a positive test on day 3, that doesn't guarantee that you're not going to develop symptoms at day 7, 10, or 11. So, understanding a little bit about the positive and negative tests, I think, is important. The next question says, what guidance is being given to hospital on who to test? Hospitalized patients with symptoms would certainly be, the highest priority, but I think testing, especially as hospitals open up, routine procedures is probably going to be used on asymptomatic, preoperative patients as well. I imagine that we probably do have some guidance directed at hospitals. I just don't have that right in front of me, but I can try to identify the link and
we have
send that
on our website, so our members can go to the LeadingAge Virginia coronavirus page and see the latest guidance that we developed in collaboration with VHHA, VALA, and VHCA, and that guidance has not changed since it was originally released. What was it, 2 weeks ago, Dana?
That's right.
Yeah, and but there is a task force that is looking at testing and specifically upon discharge to long-term care settings. So that task force met last week, and I believe they're meeting again this week. Tracy Jennings, correct me, or Sarah, correct me if I say anything inaccurate. So they are continuing to look at what the strategy should be around discharging folks to long-term care settings. Oh, and Tracy just said I'm correct, so that makes me feel validated.
Awesome.
And then there was one more question that came in around, will the 2% be a representative sample of the population as a whole? Otherwise, will data be reliable from Virginia Gov?
I'm not sure whether that would be a representative sample as a whole. That would be a statistics question, and I've probably forgotten more statistics than I knew in the first place. I think it's set as a general, kind of general benchmark to, to build our data. And we're hopeful that, it would be a reliable benchmark to look at. It is what other states have been guided by, the other metrics certainly that the governor and the state are looking at, as well as, number of people hospitalized and mortality data. So I think probably putting all that together as a bundle and, making the best decisions that we can in terms of, decreasing some of our social distancing efforts will be, what's used to guide our path forward.
Well, thank you. Those are all the questions we had. And I know, Dana, you want to update folks on our letter to the governor that we sent last night.
Yeah, thank you so much. Thank you, Dr. Cornegay. That was really helpful. We appreciate you being on today. I did want to update everyone that yesterday, LeadingAge Virginia, along with the Virginia Healthcare Association and the Virginia Assisted Living Association, submitted a letter to the governor requesting that he would make priority testing for all hospital discharges for folks that are being transferred to a nursing home or assisted living long-term care setting. So we're really hoping that will be, we know that there are hospital systems that currently are doing that as a best practice, but we are asking that that be a priority for all hospital discharges for folks to be transferred to a long-term care setting. We received confirmation from the governor's office last night. It was a positive response. They said that they would do all that they could do to comply. So we'll keep you posted as we continue to work with the administration on that. So now I'd like to go back to Barb Brannon to talk a little bit about her experience with the PPS. I think you might have to unmute yourself, Barb. Okay, well, Jody.
Wait, let's just give it a second.
Okay, all right.
Let's not pressure Barb to find that unmute button. And Paula, if you have the ability to figure out where she is and unmute her, that would be most helpful too.
I'm trying, but it says she's not connected to the thing.
Barb, if you're there and you can tell us where you are, put it in the chat box and we'll find you.
In the remote world.
Oh, thank you, Kelly. Barb, you may have to press *6 to unmute yourself. Thank you, Kelly, for knowing GoToMeeting better than you do.
Yay! Hello, team.
Hi, Barb. Thanks for joining us.
Well, I've been here all along faithfully. Thank you, whoever Kelly is, for the *6.
Kelly is an awesome representative with the Virginia Healthcare Hospital and Healthcare Association. So thank you again, Kelly, for teaching us how to use our system.
And you gave me my voice, Kelly, which hopefully none of you will regret. But thank you so much for inviting me to talk about our experience with point prevalence survey. And I will preface it by saying we were the first community in Northern Virginia to be offered this testing. Our outbreak began a little over 6 weeks ago now, and it was in healthcare, of course. We put PPE in place and optimized it with assistance in getting all the materials we needed from partners and from the state. We had PPE to the extent we had it in place prior to our outbreak, and we had taken early precautions to prevent an outbreak, which unfortunately were not successful. So we worked closely in managing the outbreak, and 4 weeks into it, we had had a few days with no new cases in either staff or residents. And then we had 2 additional positive tests in residents, which, in working with our medical director, our concerns were there was some risk that had not been identified in either our procedures, infection control, or in our interpretation of how to manage our positive residents and staff. And of course, we presumed it was staff members that might somehow be positive. We started worrying that some may be asymptomatic positives, which certainly would make it more difficult for us to exclude them from the setting. So we had been asking for increased testing, and like all of you, there have been challenges in getting some of the testing that we needed. At that point of 4 weeks into our outbreak, the local health department said no longer to test residents because we would and were treating all as if they were on isolation and positive, and they said only test staff who are symptomatic. So with the additional 2 residents, my medical director was trying to make arrangements with a private lab to do 100% testing of all residents and all staff members in our health centers. And we have 2 assisted living units and 1 nursing floor. So I called the Loudoun County Department of Health that following morning and asked if we could get any state assistance with the 100% testing. The answer to that point had been that the testing was very limited and they would not be able to offer additional support. But on that Friday, they said, I'll check with the state. And our request coincided with the new point prevalence survey capability. And the state said, yes, they would like to do that survey in our community. This was on a Friday. We asked if it could be done as soon as possible. And indeed, we were able to work with the state health department, the county health department, the National Guard, Virginia, and also the University of Virginia over the weekend to coordinate all aspects of the testing, which would be done that following Tuesday. And I will tell you all that it was an extremely positive experience from the management of the coordination to the arrival of the National Guard bright and early that Tuesday morning. They mobilized with 7 vehicles, large pickup trucks with covers on the back, a couple of trailers, and they had a team of 37 guardsmen and women. 5 of those were medical testing teams, or there were 5 medical testing teams among those 37 who were to be deployed to do the actual testing. One of our assisted livings is slightly off campus from the rest of the healthcare areas, so they deployed 2 teams to those areas. Residents were tested in their rooms, and staff members were tested in an area that was separate from the actual units and could be accessed from the outside. The National Guard set up decontamination tents on the patio so that their staff members could be decontaminated when the testing was done. And the guardsmen came in full hazmat style protective gear with very elaborate respirators. They said it was probably more than they needed in that case, but they were well equipped and well prepared. The testing, there was a lot of preparation we had to do prior to the testing. There's a lot of paperwork that has to be filled out, and we had to use the resident face sheets to put data on these forms. And then we had to create line listings, and we did that in conjunction with the health department. so that every test, we had the date of birth of the person who was being tested. They were all numerically sequenced to match numbers on those testing tubes to keep everything straight and organized. Also, during that testing process, our director of nursing checked every person who was getting a test and coordinated the numbers and the paperwork with that test tube. So we felt very confident that the tubes were correctly identified when they went into the laboratory. We had a total of 220 individuals tested, and the testing itself took approximately 4 hours to do. The teams are quick, but it is an individual staff member process, and only one is in the area at any given time. And so we had to manage the social distancing and the scheduling of those staff members to keep the whole thing running smoothly and as quickly as possible, and also to protect everyone from inadvertent contact. 157 staff members were tested and 63 residents. We did not retest any residents who were in isolation due to positive testing and were within that initial quarantine period. We did test 5 staff who had previously tested positive and had met the criteria to be released from quarantine, but were not yet back to work. We also tested 5 staff members who had been returned to work based on the guidance and previous criteria from the health department. The results came back somewhat sporadically. Apparently the university at that time with this testing was batching them in groups of 90 or something of that sort, but they were mixing them from different facilities, different areas. So our results would come back maybe 10, 15 at a time. They did not come back to a central point. Most came back to our medical director, or she was able to get the results from the local health department. And of those test results, first of all, we were very delighted to see we did not have any additional resident positives from all of those who were tested. We did, however, have staff new positives and staff who were positive still, despite having completed quarantine and having been asymptomatic for up to 3 weeks. And I think that is the real benefit to us, because it confirmed our concerns that we had asymptomatic positives and that staff might not have been able to or safe to come back to work, because despite being off work from 2 to up to 4 weeks, 5 of those still tested positive. So of course, they were put immediately back on quarantine. They will not be allowed to return to work until they have 2 negative tests at least 48 hours apart. And that is certainly different than the recommendations that we had received prior to our point prevalence testing. We feel much more confident that we can better manage our outbreak at this point and hopefully bring it to a conclusion. We are not able to, at this time, get support for those additional tests from the state for the 2 negatives that are really needed before we can return people to work. But I did hear you, Melissa, talking about that in the media, and certainly I think that should be a standard practice, and I believe it is now a new recommendation that happen. I did hear a question prior to my talking from someone about, can you make staff get tested? And I will say, yes, we determined we could to the extent staff were told, yes, you must be tested in order to safely continue to work. If you test positive, we will support you through a quarantine and we will retest you. If you choose not to be tested, you will not be allowed to return to work until such time that you are tested and test negative. And so those who had been reluctant, certainly stepped up and were tested. You cannot compel residents to be tested, of course. And we did have a couple who did not wish to be tested, but we continue to treat them as though they were positive. And so they really are not a risk. Our medical director has determined she will continue to do weekly testing on all of the residents unless they refuse, because we're very aware that because that point prevalent survey told us people were negative, it is a point in time. And so she wants to repeat that every week so that we do not become surprised by a new wave of cases. And I don't know that there's much else I can add. They did require that we have and identify to the state a plan that we would have in place on how we would respond to the identification of any positive staff and residents. And ours was put together very quickly, so ours was a verbal plan, which was accepted. I don't know if they have a written requirement now, but we really just had to assure them that we would and had the capability of immediately putting any positive resident on isolation, and our staff would be equipped with full PPE and appropriate PPE to care for them, that any staff who were positive would be put on quarantine for 14 days and then not return to work until they had 2 consecutive negative tests at least 48 hours apart. And we also gave them listing of the staffing agencies from whom we could get additional support to cover staff who were on quarantine. And we incidentally have had to use a lot of different staffing agencies to maintain adequate staffing since the beginning of our outbreak, due to not only our own staff on quarantine, but due to the fear of other staff and their reluctance to work with COVID-19 patients. So it has been a challenge. I think we are in, touch wood, good shape now. And I think our staff and our processes and procedures are well instituted and working smoothly. And for now, we do not have any PPE anxiety because we have been getting regular assistance from the state since we have had an outbreak, and we certainly hope that supply continues. We've also accessed from many other sources that others have shared with us. So thank you. I appreciate the opportunity to share this with you. I would urge everyone to consider doing this because it gives you a lot more information on what you should do going forward.
Barb, I have some questions for you that came in, if you don't mind.
I don't mind at all.
Okay, so one around testing capacity. How do you have the testing capacity to continue to test all residents each week?
Actually, my medical director was available to find a laboratory, private laboratory that has the capacity to supply us those test kits. And we do have nurses who are trained to do those nasal swabs. So we will go ahead and do that privately. For residents, it is covered under Medicare. So essentially, it's only the transportation of those that is going to be something that we'll have to manage from a cost standpoint and logistically. For staff members, it's $100 a test, and we will continue to do all the negative tests, retesting, until staff can come back to work, and we'll use that private lab. So hopefully it won't be an extraordinary expense, and that people, we won't have a lot more of the successive negative tests. Right now, I think we have about 14 staff members who will be requiring negative tests in order to return to work.
What's the turnaround time with your private lab, Barb?
It has been generally shorter than with some of the other labs. I would say 2 to 4 days.
Okay.
Oftentimes 48 hours. So we're pleased with that. Many other times we've waited 7 days or longer for some tests through local hospitals and other labs.
Are you requiring agency staff to be tested prior to coming on campus to start working with you?
We have not thus far, but most of the agencies with whom we work are doing that, because as any of you using agencies know, if you have an outbreak, their COVID-19 rates for their staff are tremendous. And so we felt pretty confident in saying, if we're going to pay this much, you have to give us folks who are symptom-free and have been tested.
And are they?
But they still have to have PPE, because even if they're tested, that's a point in time again.
Yeah. Are they only working at Falcons Landing, the agency staff, or are they working in multiple communities? Do you know?
We have told those agencies with whom we work that we want dedicated staff, and we want the same staff sent to us, because we don't want to share them. And, we have to have some trust in that. We've also told our staff, if they have other jobs, they should notify those jobs that they work at a community with an outbreak, and they need to select where they are going to work, because we don't want them going back and forth. But again, we don't have control over that, and we can't even, we don't even have a way to ensure our staff disclose other employment.
And then, so a follow-up, have they implemented that on their screening? That would be an indicator to audit with regards to staff working in multiple communities.
Was that question for me?
It sure was.
Okay, please clarify. I'm not sure on what screening.
I'm assuming, Brendan, is it screening at the gate before they come on campus? Is that what you mean? Yeah, entrance screening form.
No, we have not done that. We do ask if they have had any contact with anyone who has been diagnosed with COVID-19 or has any respiratory illness or symptoms. But we have not specifically asked the direct care staff. I do not know. We do a secondary screen when they get to the health unit, and I would have to check with our nursing team to see if they ask those questions as well. I'm just not aware.
Last question for you, Barb. How did you handle staff who refused to work with COVID patients?
Essentially, I'll be real honest with you. Many of them used some of those wonderful programs that have been set up for people who can go out and still get paid a percentage of their salary for 2 weeks if they have childcare, if they have sick people for whom they care, and so it was elusive. We suspected they were not willing to care for them, but they had many other reasons that were keeping them out, to include symptoms, which oftentimes in some cases went on for a month, where they had vague symptoms.
Yeah.
So, what are you really going to do? It put us in a difficult situation. You can't compel them to come and work. We did not furlough any. We did not terminate anyone.
Thank you, Barb, so much for sharing your experience.
Oh,
with membership.
one other thing,
Okay.
Melissa, we did institute some pretty healthy staff bonuses per hour or staff COVID-19 premiums to the hourly wages for every single person who worked in any of the healthcare units, to include housekeeping, dietary, and maintenance. Many were much more eager to work once those were instituted. So money didn't talk exclusively, but it did help, I think, once people became more confident that the PPE was available. It was very difficult when it was sketchy and we had trouble supplying 100%, but once we started putting 100% PPE on every single person in there, it gave people some index of comfort. Housekeeping never came back. We've had to have ServPro and maintenance folks helping the few housekeepers that continued to work for us. That has been a huge issue here.
Well, thank you so much, Barb. I know we're over time. Sarah, do you happen to still be on the phone, Sarah Lineberger? Probably not. The question came in, is VDH considering possible restrictions on people working in multiple communities? And I would say that the guidance is, the recommendation is that people don't work in multiple communities where there's an outbreak in one of the communities in which they work. But because staffing is such a shortage, I don't know that there will be any quote unquote restrictions put on that. And as Barb said, it's hard to know when staff are working in multiple communities. Looking at the time, just want to see Jody from LeadingAge. I know how fast you are. Are you still with us?
I am here, yep.
I turn it over to you if you don't mind giving a quick update.
Yeah, quick update on the reporting. So CMS did release the rule on the nursing home reporting requirements. It is currently in public inspection and has not yet been published to the Federal Register, which means it is not in effect yet. It will go into effect when it's published, which right now is scheduled for Friday, May 8th. It applies to nursing homes only who are certified by CMS. There's been a lot of confusion about that because CDC's module allows for reporting by both nursing homes and assisted livings, and it doesn't matter whether you're CMS certified or not. But in terms of the requirement, it only touches those that are CMS certified nursing and skilled nursing. The rule requires two things. First of all, that nursing homes are reporting to CDC on a weekly basis, at least. You need to be reporting suspected and confirmed COVID-19 cases of both residents and staff, total deaths and COVID deaths for residents and staff. You need to be reporting information on PPE and hand hygiene, ventilator capacity and supplies, resident beds and census, resident access to testing, staffing shortages. There is CDC training available for this. They've had a few trainings with live Q&A after over the past this week and last week. Those slides are posted. The recordings are not yet up, but they should be up in the next week or so. And I just saw this morning that CDC actually has 4 Q&A sessions scheduled. One is today, another one tomorrow, and then there's 2 next week as well. And those will cover both the enrollment process and the module. The second part of the rule is resident and family notifications. Nursing homes are required to notify residents, resident representatives, and families by 5 p.m. the next day following a single confirmed case of COVID-19 or a cluster of respiratory symptoms, and the cluster is 3 residents and or staff in a 72-hour period who develop respiratory symptoms, Also required to provide a weekly cumulative update to residents, representatives, and families. And these notifications need to include your mitigation strategies, any disruption to normal activities such as visitation or group activities, communal dining, once all of those things resume. And CMS notes that this does not need to be taking place in the form of an individual phone call. You don't need to be getting on the phone and calling every single family member that you have on your face sheets. You can use website updates. You can use a recorded phone message that folks can call into. You can send out mail. You can put up flyers for residents. You can put flyers on the dining trays. However you can communicate to meet those requirements. How's that? Was that quick enough?
That was fabulous, Jody. Thank you so much.
Sure, no problem.
Thank you to all of our guests today for presenting and for taking time to share their knowledge and their experience with our membership. Tune in next week, Wednesday, May 13th at 11 for our next call. Until then, if there's anything that you need at all, no ask is too great or too small, just email Dana or myself, and we will get to work on whatever it is that you need. So thank you so much for your membership and your attention, and stay well.